see them in their med school building. This works out. Where's my lecture? Pulling it up. There we go. All right, let me grab this guy and then share screen, right? So I won't be able to see your guys' questions, so I'm going to rely on at the end of the slides to answer them all, if that's cool. But I guess it should be time to start. So it'll be 12:07. Can you guys see this title slide? I just want to make sure. Yep, cool. All right. So I was having to do a quick presentation on asthma for the internist. I did COPD on Wednesday. So for those that were there, thank you for attending. This one is overall asthma associated only. So our objectives for this presentation, again, sorry to introduce myself, I'm Patrick Kosciuk. I'm a third-year pulmonary critical care fellows. I'll be the interventional pulmonology fellow next year, essentially starting in July in a month and a half or so. All right, so we're going to talk about asthma before I make my venture to interventional pulmonology. So at this point, we're going to try to be able to diagnose it, determine the severity of a new diagnosis, determine the treatment of a new diagnosis, assess for a long-standing treatment, and to treat as well. To also be able to step down therapy appropriately once people are well controlled. So those are the objectives. We're going to kind of go through a few things rather quickly and a few things rather more slowly. There will be a few questions on the road as well. Asthma diagnosis. So a lot of my slides will be coming from the Gena guidelines. These are most recently updated in 2019. The other slides will be from the NHLBI, which that was updated in 2012. And I'll try and make a lot of these distinctions for you guys once we when they're necessary and ready. But this is all Gena right here. This is a little bit different than what it's been in the past. So are the symptoms typical of asthma? All right, yes, and we'll talk about those symptoms in a little bit. Does the detailed history and exam support asthma? If the answer there is yes, I mean, you're moving into one of two categories here. Classically, when we were talking about clinical urgency and maybe providing some degree of relief for asthma patients, we were talking about providing a PRN, short-acting beta agonist, and that's typically albuterol. But largely, the guidelines are now moving into the realm of, is this an urgent diagnosis and they need to start on treatment ASAP because of how bad their symptoms are? Or do we have the luxury of time and can we figure out a way to reliably confirm the test? If we have the clinical urgency route in actually providing the patient with some relief, because we can't schedule PFTs rather quickly, you can typically get them in within 2 to 4 weeks easily. But if you feel like you necessarily need to start treatment, the move is to start an inhaled corticosteroid actually off the bat. And there's a lot of importance in this, and we'll talk about that later on, to review the response and certainly try and get that testing done, because you have relieved some of their complaints, arguably, within 1 to 3 months. Again, this is the whole idea of a clinical diagnosis without confirmation. And typically in the past, we've just given them albuterol as needed, but now we're trying to make it more defined to start with this ICS. I think it's very important to start with a low dose ICS. Inhaled corticosteroid is what that refers to. Otherwise, we do have the luxury of time. Let's look at PFTs. Let's figure out what their diagnosis is. And we'll talk about other ways to confirm the diagnosis, because it's not just a single PFT to say, all right, that's it, they don't have asthma, but there is some value in looking at variability over time. So these are incredibly important steps, especially for the internist moving forward. Asthma is unfortunately a non-specific complaint a lot of the time, so making that diagnosis is challenging. As we move forward, well, let's see if it will move forward for me. Good. So symptoms. So what are we looking for with these symptoms? Like we said, we have this non-specific complaint, but let's look at likelihood ratios here. So people are at increased likelihood of asthma if they have more than one of the typical symptoms. And again, if you think about it, shortness of breath and cough, maybe that could be chronic bronchitis, chest tightness, here's some cardiac symptoms, wheezing, really nondescript. Could also be cardiac wheezing, right? This is pretty important here, teasing out the idea of nocturnal symptoms or very early morning symptoms. This is more classically asthma. These guys are also variable in terms of their intensity of their symptoms, as well as whether the presence of symptoms is there or not. Typically similar to COPD, you'll have triggers for asthma as well, whether it's viral infections, exercise, again, exercise-induced bronchoconstriction, allergens, a variety of things. So these are all important things that you can try and mitigate for patients and advise them to try and avoid some of these. Notably, you have less likely asthma with just an isolated cough. And I know that in your algorithm for a new cough that's kind of chronic over time, that you start to think of what? I mean, it's asthma, it's GERD, it's some sort of rhinosinusitis, some sort of upper airway problem. But an isolated only cough without other respiratory symptoms is less likely. So if you don't have your classic wheeze, if you don't have shortness of breath even, it's probably less likely. If you actually are a sputum producer, probably less likely. If you have shortness of breath with any sort of other associated symptoms that oftentimes can be associated with maybe even cardiac phenomena, probably less likely. True chest pain, so this is the sharpness. This isn't that dull chest tightness that people feel that's like pressure related. I mean, this is the sharpness, less likely, again. Good. And so here's a large table. So here's how you can make the diagnosis of asthma. On the left is the terminology for it. These are all Gena guidelines 2019. And on the right is better defining it. Classically, we're talking about having symptoms where you have variability in your symptoms, and you also have some degree of a documented airflow limitation. I would like to highlight that this airflow limitation does not mean it's a fixed defect of 0.7, like we've been classically taught with like gold guidelines for obstructive defect. And similarly, based on Gena guidelines, they don't use the ATS lower limit of normal, which we've started to define a lot of our obstructive defects. It's largely kind of a step down pattern with the NHLBI. I mean, so a normal is considered higher than that, certainly in younger individuals. A normal is higher than like 0.75 or 0.80. But to better define it within the way that we standardize tests, we arguably still use an ATS standard of lower limit of normal. But you can also try and get asthma a different way here in terms of a diagnostic reliability. You can get it with a positive bronchodilator reversible study. So again, they don't have to necessarily have expiratory airflow limitation, but they can have a positive bronchodilator, and that can help to rule in or suggest asthma. It doesn't mean they have it necessarily, but the more of these increases your likelihood ratio of having asthma. Classically, we're taught that we see an FEV1 or FVC increase of 12% and 200 cc's from baseline. Notably, in the Gena guidelines, they say you have a more confident diagnosis. Again, this is a much higher likelihood ratio if you have greater than 15% and greater than 400 cc's improvement. And again, if you think about it, all these people should be at a point of normal lung function. They should not have deterioration from any sort of other underlying lung disease. And so you'll typically actually see these values that are much higher in these settings. Asthma COPD overlap, a little more challenging, certainly. You can also give them a peak expiratory flow meter, where you can look at their variability if you ask them to do their study once in the morning, first thing early morning, and once later on in the day over 2 weeks. And if you see a lot of variability over the course of the daily diurnal measurements, over 10%, that can help suggest it. I mean, this is something that you can provide for these patients and ask them to do this in a diary fashion. You can also see this one, which is a little bit trickier. So this is where you give a patient some degree of either a steroid course for 5 to 7 days, and then you repeat their lung function after about either 4 weeks of a treatment course or within 2 weeks typically of steroids that were given. And if you actually see your improvement in your FEV1 during this time, that might be helpful to say they might have more likelihood of asthma. As we look at other tests that we have available to us, we have both direct challenge tests and indirect challenge tests. A direct challenge test is essentially where you are effectively acting on the airways themselves. So methacholine or histamine are part of it. We're classically taught methacholine. I just wanted to let you guys be known and aware that we have other tests, indirect tests, where we act on the tonicity of our airways. So mannitol, hypertonic saline, and then essentially where you dry out your airways with hyperventilation. So these are separate tests that you can use to help rule in different types of asthma, like occupational asthma, exercise-induced bronchoconstriction, again with exercise challenge, a variety of things. Probably the least reliable, although maybe suggestive of asthma, is if you bring people in for PFTs at each visit that you see them, and they have their own inherent variability of their FEV1 percentages and volumes. And this helps to essentially drive this excessive variability idea of asthma. And so this could be helpful. So again, nothing is super 100%, oh yeah, you have biopsy proven asthma, but I think a lot of it has to do with likelihood ratios and how you make this diagnosis. And I think it's important to at least say, I think they have asthma because of this, and here's my supportive information to provide that diagnosis. And if you're having a hard time with making that inference, you've started them on some degree of therapy, it's not unreasonable to have a pulmonary consultation to evaluate truly whether they have asthma or not, especially if they're frequently hospitalized for this problem. Again, I wanted to highlight the bronchoprovocation challenge here. The direct stimulation of the effector cells has to do with the airway smooth muscle cells, bronchial endothelial cells, mucus-producing cells, and results in airflow limitation. Some argue that maybe there's a better degree of airway inflammation if we don't act directly on the effector cells and we act on intermediary cells here. And these are mast cells, again, very classic in essentially an allergic phenotype, right? That acts on eventually the effector cells, or whether the neuronal cells are acting on them. And so we call this entire column here the late phase allergic reaction. And this is essentially the direct early phase allergic reaction. So whether the stimulus that's acting on these cells is associated with essentially exercise, being physical, pharmacologic, being increased osmolarity or tonicity of the solution going into the airways, they're arguing maybe this is promoting more inflammation in these airways. So again, direct stimuli, methacholine and histamine are important to know. Indirect stimuli, weirdly propranolol. Again, when we start talking about maybe avoiding non-specific beta blockers in the setting of asthma, maybe we're starting to look at these processes, but I'm not going to belabor this point. I think this is a tricky problem overall, beta blocker use in the setting of asthma. Exercise, hypertonic, hypotonic solutions. In the past, they had done distilled water indirect stimuli challenges on the airways, and then someone died and they stopped doing that. But I mean, you can use any sort of osmolarity solution to really mess with that system. And then this more pulmonary critical care fellow associated test, the isocapnic hyperventilation, which I won't, is beyond scope of this. So I guess I'll, and so then I will belabor a little bit of the methacholine challenge in this setting, because this is the one I think most people are familiar with. The importance of this test is if you're kind of unclear whether you have a diagnosis of asthma and you're looking purely at asthma. This is not occupational asthma. This is not exercise-induced bronchoconstriction. This is asthma, all comers kind of. So it's not a super specific type. A negative test has an amazing negative predictive value. So they probably will not have asthma in this setting. And how do you interpret it? Well, you're trying to determine a concentration of your methacholine that will reduce your FEV1 by 20%. And so we're trying to hone in on this concentration, essentially to be either less than 1 to 4, to truly say, all right, well, they probably have asthma. If they have studies essentially above 4, some people argue that it's probably not asthma, and you can say that it's not even a significant test. And anything above 16 is certainly normal. The caveats are that people will typically need to stop some of their medications prior to this test because well-controlled asthma can have a negative methacholine challenge. So it's very important for patients to have certain medications held for a certain amount of time before they undergo a methacholine challenge if you truly want to get them off their meds and you don't think that they have asthma. So there are tables and up-to-date to look at. I won't belabor those outside the scope of this. Typically, a lot of those medications you hold are actually the beta agonists or the antimuscarinics, and that you typically can continue the inhaled corticosteroid. And if it's a combination inhaler, then you'll just hold them both at that time period. If you're really worried about the patient, you could prescribe them just the inhaled corticosteroid to use while you de-escalate them to get appropriate methylcholine challenge. But it's really important, again, if you have controlled asthma, your methylcholine challenge probably will be normal if you do it. Your contraindications to the methylcholine challenge, again, you can't bring someone that already has a terrible defect to undergo a test where that defect will get much worse. So severe airflow limitations are contraindications. The ATS published guidelines in 1999 that said less than 50% we probably shouldn't be doing. The ERS did a little bit higher, some more safety profiles of less than 60%. You shouldn't have had any sort of cardiovascular or central cerebral insult within the past 3 months. You certainly don't want it with a high blood pressure. And interestingly enough, although we always put PFTs on for surgical clearance, a known aortic aneurysm that they're going to graft or repair, God knows what, you probably shouldn't do a methylcholine challenge to that patient population. So I'll provide you with a question to lead into our next category. And that question is, we have a 42-year-old woman comes to our clinic with a history of morbid obesity, hypertension, diabetes, and a reported history of asthma. She's already on a moderate to high dose Symbicort. So that dosing is 160 of the budesonide component and 4.5 of the Formoterol component. Albuterol as needed, a blood pressure med, a diabetes med. She complains of persistent shortness of breath that occurred for the past 4 years, largely stable at this point, I would say. Denies any nocturnal symptoms, uses her albuterol essentially once per day, I'll say in this question. Never had childhood asthma, never had lung function studies. So what should we be doing for this patient? What should be our next step, especially because her symptoms are still persistent? So would you say to continue our current medications? Would we add a LAMA? Would we cut our dose of the Symbicort in half and reassess with Spiro? Or should we stop at cold turkey and reassess it with Spiro? I'll leave the question out there. We'll do it for a minute, and then I will go to the next slide. If you guys want to answer the question by sending me the answer, as opposed to answering in the larger chat box, I'm happy to review you guys' answers. And then Gene, once the timer runs out, do you mind just saying, question 1 end or something? That way I can look at the responses later, just based on this computer, please. Oh, it's on my phone. I'm just looking at it. I don't know how to use WebEx. I can use Zoom just as fine, but I don't know WebEx that well. Sorry, Gene. I'm gonna give it another 15 seconds. Feel free to send me you guys' answers privately. All right, that's been a minute. So I'm going to close this guy and this guy. All right, and so our answer to the question is to cut the dose of Symbicort in half and to reassess with the spirometry. Again, if you're really worried about these patients, sometimes you have to take it a little bit slowly and really figure out these diagnoses. So here's your step down idea if you have not confirmed your diagnosis. This happens a lot of the time in our patients, especially if they've been inpatient, and we don't know the diagnosis, but we can't have PFTs on them. So if they're already on asthma meds, but we have not confirmed the diagnosis, we need to step down our controller to confirm it. So we document the patient's current status, including their asthma control and lung function. If they are at high risk for having exacerbation, try not to do the step down. You need to really closely monitor these patients if you do. Find a good time for the patient. Again, no overlying comorbidities that are acute during that time, including pregnancy. And then also give them a written asthma action plan. This is an important step for everybody. What you do is you reduce your ICS dose. Again, these are people with asthma. They should be on their ICSs, right? You cut it in essentially half. And then you schedule either for review visit or PFTs within 2 to 4 weeks. As we move forward, we repeat our asthma control assessment, lung function in 2 to 4 weeks. like I said earlier, and then you can end up deciding whether or not to go back to the higher dose if you've truly confirmed their diagnosis with PFTs, or let's say their symptoms are about the same, they haven't changed, they do not show this obstructive defect, then you can consider just getting rid of their controller altogether. Just get rid of it altogether, the ICS definitely. And then repeat an evaluation in about 2 to 3 weeks, and then continue to follow them for a year or so for these asthma complaints. But at that point, you've safely gotten rid of the diagnosis of asthma from these patients. So you are trying to figure out, and you've made a new diagnosis in a patient, right? You've done it de novo for these patient populations. 2 different metrics are being used to determine the severity of a patient. This is a large chart. I won't belabor every portion of it. I want you guys to be aware of it. This is the NHLBI chart. So you can use NHLBI to determine how severe someone's asthma is even before you've got them on controller medications. This is off the bat, de novo, new diagnosis of asthma. You can categorize them into intermittent, mild, moderate, or severe. So just something to know about. Interestingly, in COPD, we grade COPD severity by their FEV1s. In asthma, there's no such grading system, because typically you'll have normalization after a bronchodilator response, right? Or after you have adequate asthma control. It is, however, a strong independent risk factor for exacerbations if you have a low FEV1. The Gena guidelines, you will not get a severity off the bat. A new diagnosis of asthma, you cannot determine how severe someone is. So according to Gena guidelines, it doesn't really matter, like you're hitting them heavy with medications, but it doesn't matter what their initial severity is. Because someone can have an insanely severe score, severe symptoms, but if they just do ICS low dose monotherapy, they can all of a sudden rapidly be well controlled. So that does not mean that they have severe persistent asthma based on their symptoms with a new diagnosis, because they're on very minimal therapy. And so all of a sudden, you should not categorize people as severe asthma, right? You have to be on controller therapy for several months in order to say how severe someone is. So how about another question? Good. So a 20-year-old woman referred from her PCP, worsening dyspnea. This is pretending you're a pulmonologist, I guess. Over the last 4 weeks, complained of daily dyspnea and wheezing. Awoke from nocturnal coughing once in the last week, twice in the preceding week. No other reasons for cough present, at least. We have PFTs that show her FEV1 FVC is 0.72. I would like to stress that, again, it is above 0.7, but the lower limit of normal for a 20-year-old is certainly higher than that. And her FEV1 did increase by 14%, with increase from 2.77 liters to 3.16 liters. So what med would you start this patient on? I'm going to start the timer. If you guys would like to send me your answers through the text, that would be great. All right, so there's our timer. So the answer is C. It's low dose ICS LABA. So a combined low dose ICS with LABA. Another answer that would just as well be good is medium dose ICS, but you should not have the LABA on board with that. So that's something to know about. And a lot of that ends up having to do with looking at these tables for treatment strategies. And so as we look, we see within the NHLBI that below this table, which I cut out earlier, you'll see the degree of steps to end up adding the medications onto these patients with this degree of initial severity. And then they use this stepwise fashion. So again, I'm not going to go over all of this stuff, right? I mean, so you can see typically people would start, you know, in these lower categories, arguably with a low-dose ICS, it goes low-dose ICS plus LABA and so forth. But if you have more severe symptoms, which Our Lady did, where she ended up essentially having the indication for step 3 of therapy, right? So she ends up having essentially some limitation of normal activity, has daily symptoms, typically greater than 1 times per week awakening, but it does not happen nightly. I mean, it kind of fit her overall. And so step 3 therapy was most appropriate. I like to use the Gena guidelines, and I think everyone should probably look at those ones more likely. So Gena guidelines have been more updated. They include all sorts of things like biologic therapies, which NHLBI typically has not caught on to yet. And so what does Gena say? So for the initial diagnosis of asthma, you don't always have to start at step 1 or 2. And so in this patient, we're talking about essentially having troublesome asthma most days, awakening due to asthma greater than or equal to 1 time per week. And so this is a patient that you would start on low-dose ICS LABA relief and the SABA, or again, a medium-dose ICS, but not with the LABA included. So it's either low-dose Symbicort or medium-dose mometasone or beclomethasone or monotherapy budesonide, all sorts of stuff like that. This is all alphabet soup once you get to these inhalers, really. So after we provide these initial medications to our patient, they were recently diagnosed with a new severity of asthma. What can we do for them? Provide them with a peak expiratory flow meter. This might be something to chat with your chief residents to figure out how to provide them for your patients in the Hawksworth clinic setting. Some clinics will have these available that they just hand out to patients. Sometimes you have to use prosthetics consult. So something to probably chat with whoever's the clinic chief to figure out how best to give these medications, or how best to follow these patients, really, not the medications, but to follow them with this peak expiratory flow. So after you've started new medication therapy, typically with an inhaled corticosteroid, again, in asthma, inhaled corticosteroids are the most important part. You do want to see how well they do, and within 2 weeks, they should actually have their peak value. And that is something that will have to be documented for them in their note. It's important too, if they do have one of these meters. As you continue to follow them, once you treat them, you'll start to see a reduction in their AM reduced flows. Again, remember, asthma is very nocturnal versus very early morning disease as well. So you'll start seeing better control of their early morning disease within the next 3 months, essentially. Yeah. So who should get one if they've already been on asthma therapy for a while? People that have severe asthma, so frequent exacerbators. It's really important. And a lot of these are important to tell because you need to create an asthma action plan for these patients. And see, here's an example of one. You have a green, a yellow, and a red zone. Here is where they document that first best peak flow. And so they can monitor and determine what to do when their peak flow decreases. And so you have very well-defined structure of what to do. Additionally, you can also help to define them their controller medications. A lot of people use the color of their medication to help define what they do with it, because they won't be able to identify the name or the surname, right? Because budesonide Formoterol, also known as Symbicort, is also known as, insert color here, inhaler. So it's important for them to know which inhaler and how often that they have. And oftentimes these are younger people, so potentially they have a little more medication non-adherence just based on new diagnosis and not many other medical comorbidities. So it's helpful to get it all nicely listed so that they are well adherent to their medications. And you can create other plans, including taking prednisone or all sorts of other things. But here's a nice example. The periodical is Supported Self-Management for Asthma in Breathe of 2015. So take a look at that guy and maybe create some of these plans for these patients. So long-term therapy of asthma. So we've made the diagnosis, we have followed how to monitor it, we've started treatment of a new diagnosis. Now you're going to start seeing these patients in your clinic, and you'll want to see how they're doing on their therapies. As we move forward, we need to assess their asthma symptoms. And so all of these questions are typically not over the past day, not over the past week, but over the past 4 weeks. You want to ascertain a longer period of time that they have asthma. So how frequent are their symptoms in terms of days per week? The nighttime symptoms are important to assess for. How limited are they in their activities? How do they need to use their rescue inhaler to get through these activities? Notably, when you are documenting how often someone's using their rescue inhaler, some patients will use it preemptively before they do exercise, because exercise-induced bronchoconstriction is part of asthma oftentimes. So you typically don't include the number of times they use it if they schedule it before exercise, or at least if you ask them to schedule it before exercise. So that doesn't necessarily say that it's a rescue use. It is a preemptive use, just to know. And again, here's that NHLBI table, a little bit on the clunkier side, really hard to kind of tell where someone fits. Sometimes people will fit maybe the symptom score and not well controlled, but their nighttime awakenings aren't that terrible. It's hard to kind of use some of these tables. So I use other metrics of assessing control, but this is something that you'll see, and sometimes attendings will ask you based on this. Additional means to assess someone's control. So what is the highest FEV1 that someone has? What's their personal best? And then determine what their future values look like. A change in FEV1, again, more variability in their pattern means that they probably have less control of their asthma. So you can theoretically say, all right, I have a guy that had a great FEV1 in his clinic visit 4 months ago, and now the FEV1 is much lower. Maybe I can increase the ICS component, especially with higher symptom scores, and then eventually repeat the spirometry and see if it actually gets any better. Arguably, if it has not changed, you probably go back to the older, lower dose in these cases. Of note, I think it's important to look at a minimally important difference. This is essentially a minimally important clinical difference in a lot of cases, and to really see whether your intervention has provided any benefit in a scoring rubric or a test. You need to evaluate this value. And in terms of asthma, for the degree of spirometry, that minimally important clinical difference is 10%, just for you guys to know. And so after you've essentially established how severe someone is, you determine their severity of asthma in this mild, moderate, severe category by the lowest level of medication that they have. It has nothing really to do with their symptom score, although arguably you don't want to call them a mild persistent asthma on low dose ICS if their symptoms are poorly controlled. But if they're well controlled, then you put them based on what the medication is, like where it fits within the category of the steps. So Gena is now able, again, on a controller medication to characterize asthma severity. So I would urge you guys to look at the Gena guidelines instead of NHLBI. The graphs are prettier. I mean, this thing is a lot more pretty than this clunky, like single mono shaded, maybe like 2-color system that is just, it's just too clunky. It's too clunky. This is a pretty graph, you know, it's a pretty graph. So people with mild persistent asthma start moving into the step 2 category for them. So this is just low dose inhaled corticosteroid. Moderate asthma is step 3, and severe asthma is once you have someone truly on a medium dose ICS LABA or anything higher. That's where you start thinking about all these other crazy therapies. So we can kind of look at some of these therapies here, right? Step 1, so this is when you have initially made diagnosis, right? Everyone should be on a low dose SABA. Weirdly enough, in the most recent Gena guidelines and what's been adopted in Europe, you're seeing this new step 1 problem here. You can have an as-needed low-dose ICS Formoterol. What's Formoterol in? Well, it's in Symbicort. So people can use, theoretically, a low-dose Symbicort. That's the 80 dosing, not the 160, but the 80, as needed for their asthma symptoms. Arguably in a few studies, 2 studies that came out in 2018, they showed an improvement in their symptom control and overall use of medications with this strategy. Notably, everyone is moving towards using daily low-dose ICS, and that's an important distinction. And we'll talk about that, actually. So one of the questions is, can I get rid of the ICS altogether? Can I just put them on as needed medications? And we'll talk about why that's probably a bad idea. But in terms of assessing our severity, again, in order to make any of these changes in their medications, we need to use some sort of metric of control. I would argue that this is probably the best, and this is what we use in our clinic. It's called an asthma control test. This is kind of the opposite to the COPD assessment test. So in this case, low scores are bad, high scores are good. A score less than or equal to 19 is bad. So as we look at it, we see whether asthma is causing problems in the work life, the school life, or home, whether people have shortness of breath, whether people have symptoms themselves causing them problems at night or early in the morning. Again, this is where we have these nocturnal symptoms, very characteristic of asthma. How often are we using our SABAs? And overall, how would you subjectively rate your asthma control, which is a tricky one. It's really hard. You need to make sure that the patient understands that they need to discriminate their asthma from their other comorbidities, including obesity, deconditioning, and all that fun stuff, which is challenging. But as a clinician, you're the one that's going to help them make that decision. The minimum clinically important difference for this scoring rubric is 3. So if their score has improved by 3 and increased by 3, whatever intervention you did is a good one. Otherwise, we can also see that people that are less controlled on medications when they're on their controller medications, and this is outside of that ACT score, if they start to show a new bronchodilator reversibility, sorry, this is a typo, it should be 1 here, B1, then that means they might be less well controlled. So let's go back to our medication rubric. Again, I highlighted this low-dose ICS Formoterol, and I'm putting this caveat in bold here to know that this is not FDA-approved therapy in the US, although Europe is using this. So patients that are using their ICS/LABA PRN, I guess arguably it's better than them not using anything at all, and arguably it's better than them using their albuterol PRN. So the important thing here is it has to be a Formoterol LABA. And the reason for the Formoterol LABA is because it has a quick onset of action similar to albuterol, surprisingly. It just acts for longer. So let's talk about trying to get rid of the ICS altogether. Can we do it? So here's the study that was done. They initiated treatment with 800 micrograms of budesonide daily. So we're looking at how long people had symptoms or before people were started on treatment. And so as you can see, the less than 6 months, you start your budesonide early on, and then at about the 1 year mark, you're gonna see max effect, and then it kind of plateaus out, right? As you have longer symptoms and worse control of asthma over a longer period of time without keeping this low dose ICS on, the amount of benefit you actually get from your same dose of inhaler is reduced based on the amount of years you went without getting your asthma treated. So there's some degree that maybe some of these defects are not as reversible as we thought. This is an older study again, but it's still something to be cognizant about. So maybe we should be keeping these ICS inhalers on these patients so they don't fall into these other categories of airway remodeling. Similarly, the idea is you can have terrible asthma symptoms to start, and they could be managed on a low ICS dose and just be fine and be really, truly mild, persistent asthma, even though you look incredibly terrible when you come out of the gates. It's important to know that when you have symptoms for a longer period of time, again, similar to what we saw before, that you might not have as much benefit. And so let's look at these patients here. So this is the amount of time that patients have had asthma for, new diagnosis of asthma less than a year. And we give them either 100 or 400 equivalent, I guess 200 or 800 arguably, equivalent of a steroid inhaler. And you can see if people have short asthma duration of therapy, that it doesn't matter whether it's the low dose or the high, they'll have pretty much the same benefit. But let's take someone that's had asthma for over 2 years and we give them a low dose. They really don't have as much of a benefit as the higher dose. So what does this mean? Again, this might be akin to this airway remodeling, this eosinophilic phenotype. God knows what's happening in there. But people need higher doses of steroids to get better bang for their buck once they have longer standing asthma. So again, we don't know what happens when people are on low dose ICS and you stop them. All of a sudden this duration goes out a while and then they go back and they have more symptoms. Does that mean their curve adjusts to this area here? We don't have the answer to that question, to be honest, but it's something to know about. And so again, if someone were to ask, can I get rid of my inhaler? I'm already doing so well. Why should I be taking it? I barely use my albuterol. I would keep them on at least the low dose ICS. It's important to use low dose here. Steroid dosing, what do I mean by low, medium, and high dosing? Well, here's a nice table for it. And so this is something that you guys can keep in your phone or God, wherever you'd like to. All of these inhaled corticosteroids follow this regimen where about 200 to 450 is medium, anything below 200 is low, over 500 is high, although it's a little different in budesonide. So 500 is medium and 1,000 is high. Budesonide is a medication that is in Symbicort. So just so you guys know. But here's the steroid metric here. So how long do I need to take my ICS before I truly get the best lung function I can get? In the other study, we saw a year out, but you had a lot of intervals that weren't exactly by the month. Here's a study of low dose or lower dose budesonide versus higher dose budesonide. And we see that it peaks kind of at a 2-month period. And then you start getting a plateau effect. So someone to truly get all the benefit from their steroid inhaler, 2 months of therapy would be necessary. And you can also see it here, right? Morning peak expiratory flow meter. Again, the nocturnal morning symptoms, you start getting the best benefit at about 8 months as well. Or 8 weeks as well, 2 months. So here's another interesting study that I found in terms of how often can people use albuterol. I mean, people are using it 4 times per day. God, there's so much. So we're looking at this study with frequent use of SABAs. We can find an increase in your evening flows for the first 2 days, and all of a sudden everything kind of stays about the same. And then when you stop the medication, you actually have worsening control the next day, especially in the morning, again, these nocturnal symptoms. So what did they do? Again, they looked at morning and evening symptoms for 6 weeks, and they asked patients to use their terbutaline 4 times a day. And so let's look at their graphs that they found. So run-in period, here's their morning peak flows. All of a sudden they start using their terbutaline. Also, you use albuterol, I guess, in this case. 4 times a day, you get improvement. This is morning peak flows and an evening peak flows. For the first 2 days of use, they feel really darn good. And arguably, their evening peak flows are quite a bit higher, and they sustain this. Over time, their evening still remains just as good. They feel like they can do more at the end of the day. Their mornings drop off substantially as of day 3. So they start getting used to and more tolerant of this medication back to before they start using it so frequently. And then interestingly, let's see what happens. So they are using it so frequently, and all of a sudden you stop use altogether. You have a decrease in your peak flow for evening as well as for morning, substantially decreased for morning. I mean, look at this huge drop. People feel very symptomatic, and then all of a sudden they're like, oh, I gotta go back on my med. But something to know, this whole idea of tolerance and everything. So the question is, what do I do with this information? In exercise-induced bronchoconstriction, the best benefit for these patients, if you're using it for that purpose, is using the albuterol anywhere from 2 to 3 times per week. So these are people that are scheduling exercise, doing their running groups 3 times a week. Use your albuterol before your running group. Use it 10 to 15 minutes before you start to run. It's going to work for 4 hours, 4 to 6. And then try not to use it in between. If you have to, you have to. Use it as a reliever and rescue medication. But if you really want to get the best bang for your buck, 2 to 3 times per week, again, don't try and restrict patients because they might need to use it between that time. But if they are not finding very much benefit and are just scheduling it for the sake of scheduling it, 2 to 3 times per week is best. Inhaler technique is paramount. Make sure before you end up upgrading their inhalers that you're confirming their technique and providing a spacer if their device is spacer compatible. Again, different techniques for different types of inhalers. So you can't say that you'll always get this aerosolized breath or a button. In fact, the dry powder inhalers don't have a button to press. So you can't always just tell them to press a button. Spriva doesn't necessarily have a button, I don't believe. It's a dry powder inhaler. It just stays within the chamber. So being facile and knowing what your inhaler use looks like for patients to figure that out, that's very helpful so that you don't tell them something wrong and they lose trust in you because they are embarking on attempting to be very adherent with the therapies you're giving them. It's very important. Environmental control. So what can you do outside of pharmacological therapy for these patients? I think there's a lot of value in talking about these interventions. So quitting smoking, avoiding smoke, paramount. This is important. You want to kill dust mites. You need to clean the sheets in the house in water that's over 130 degrees with a hot dryer cycle. So trying to put clothes that shrink alongside them, certainly, but hugely important. Weirdly enough, reducing cockroaches. There is no difference in just placing cockroach baits in the home versus actually using professional exterminators. But don't let those Terminex know about this. But still, this is evidence-based, better evidence. Although there's no clinical evidence to say no pets in the home, and we oftentimes say if you can get rid of your cat or dog and you have terrible asthma, you should. It's hard for the owners of pets to part with them. So the important step and the important discussion is to say keep the pets out of the bedroom. This is highly important. Keep them out of the bedroom. You might have to see that months to take action, but it's important. Decreasing the dampness in the home, decreasing your humidity. This is controlling molds. Try to go carpet free and window linen free because it'll be really difficult to get some allergens out. Although there's no clinical evidence to say this. Surprisingly, even though everyone says they uprooted their carpets and replaced them, we don't really have a good clinical evidence to continue that. Other modifiable risk factors, if you're obese with asthma, oftentimes you have a different phenotype. It's like a neutrophilic phenotype. So weight loss is huge. Oftentimes these guys are harder to treat than regular run-of-the-mill asthma, to be honest. If you have a food allergy, avoid the food. Weirdly enough, allergies to food and asthma are somehow linked. If you have rhinosinusitis, which again, your whole nasopharynx and your your upper airways and your respiratory tract are linked in a way, right? So if you have terrible rhinosinusitis that's allergic and you have the opportunity to provide immunotherapy, that could help with asthma control. You need to make sure that their FEV1 is greater than 70% when you do refer them for immunotherapy. This is huge. This is important. Something that they can find a huge benefit from. Interestingly, you have the best data for house dust sensitive patients. How do you know they're house dust mite sensitive? That's where they undergo the skin testing or the specific IgE antibodies to different. Notably, and I guess I shouldn't necessarily have it in this category, but if you have someone with asthma that had all of a sudden dropped their FEV1 substantially, you might want to consider just optimize them, either high dose ICS with 3 months of therapy, or just consider like treating them for 2 weeks with steroids and repeating PFTs afterwards. I mean, this could be life-saving in some patients, to be honest, because this huge drop in FEV1, if it's truly from asthma, could be catastrophic. So although this is not necessarily a modifiable risk factor, this is an important category to know about. Other things, Class C recommendation for an air conditioner when it's hot outside, largely because you're reducing the amount of time you have your windows open, and that reduces pollen and mold counts. Additionally, there's a Class D recommendation for allergen avoidance strategies, and this is like huge home service modeling and super expensive to do. So it's complicated and it's expensive and no one knows who really benefits, but it's a Class D recommendation to do something like that. They say it's Class D because people are typically less affected with their environment when they actually have control of their asthma. Yeah, and so in terms of actually using covers on your mattress, your pillow, your duvet, it's best studied in children. It actually reduces their ED visits, but not well studied in adults. I guess the last question is, in the last little bit of time, and I'm right at the end of my presentation, is we have our lady from prior. We started her on this low-dose ICS LABA inhaler. For the past 6 months, and the past 3 months, she's been using her SABA 4 times a week. Again, 3 times a week, like I kind of said earlier, prior to her runs, and 1 time a week as a rescue. She's only awakened about 1 time per month overall due to her asthma at this point. And her ACT score now is a 22 out of 25. Her PFTs beforehand were obstructive, and now they show normal spirometry, and they don't have a BD response, bronchodilator response. So what would you do as the next step in her management? All right, send me your guys' answers, please. I'm going to give it maybe 35 to 40 seconds this time. So I have 30 seconds for questions at the end. All right, so the answer is B. It's to step down this patient from an ICS LABA to a low-dose ICS. And again, the answers are, it's not a bad idea to keep them on the same medications, but if you can step them down, you probably should, especially now that we're trying to lower the severity of her asthma score, right? Lower the severity of what we're commenting on her asthma as. It's not safe to get rid of it altogether. I mean, you want to step down your therapies. In switching from the low-dose ICS LABA to a LABA alone, this has high mortality in asthma. So you should never have a LABA alone without an ICS. And these women's symptoms are well controlled, so you should not escalate her therapy. Notably, when we're talking about well controlled or not well controlled, again, you're looking at their SABA use over the course of the rescue use and not when you schedule it prior. So really, this woman has only needed it once over the week for the purposes of control. So treatment step down, the last part of this talk. It's important to provide step down of therapy for these patients. You want to reevaluate after you have started asthma therapy or increase your asthma therapy at a 3-month mark. And if everything's stable and if their PFTs look like they've plateaued, then you're in a good spot to consider stepping down. It's important to consider a variety of things when you're stepping down therapy. If they've had an asthma exacerbation in the past year, you have a high risk of exacerbation, odds ratio of 11.5 about. So try not to step down a patient who recently required steroids for an asthma exacerbation. And again, like we talked about before, can we get rid of ICS altogether by itself? It's a significant risk of exacerbation, about 2.35 odds ratio. And we find that people's FEV1 decreases by about 130 cc's when we do get rid of the ICS altogether. All right. Well, I appreciate all you guys' time and your attention to the asthma lecture. So I'm open for any questions that you guys have. And I really do appreciate everything you, appreciate you having you guys around and learning. All learn from each other here. I'm reading through some of these comments now. I think a lot of these are the answers to you guys' questions. There was a question on diagnosing COPD asthma overlap. Very challenging, right? Because you have a fixed obstructive pattern with COPD and you're wondering, you know, should I add singular Montelukast to these patients? Should I start considering a biologic for these patients? Very challenging. Sometimes what I've done is to look at a CT scan of their chest. If they have very minimal emphysema and they have obstructive defects, somehow, I mean, not somehow, but sometimes you can say, well, asthma is probably contributing to their obstructive defect more than COPD, so I'm going to aim for that. So in those cases, remember our talk on Wednesday, we did not want to add an ICS until we had to, until they're an exacerbator. In asthma, you have to have an ICS. You have to have an inhaled corticosteroid. So those are the people that you might be leaning towards keeping on an inhaled corticosteroid in the COPD asthma category. Similarly, COPD has very few studies, if not, very few, regarding biologics. Asthma has all of the studies regarding biologics. So in looking at the COPD asthma overlap syndrome, it's important from a therapy standpoint to give them the opportunity to have these other therapies. When you look at their PFTs, you might be able to buy in and say, well, they have a bronchodilator response, so that might be indicative of asthma, but it's not certainly diagnostic. And these are people you don't methacholine challenge. You should not. Probably what's best is to look at variability in PFTs over time. Maybe you could try to get PFTs every 6 months for a year if you're really worried about COPD asthma overlap. And as long as they're not exacerbating at the time, they should all be largely stable without variability from PFT to PFT if a patient truly only has COPD. If they have a lot of variability from PFT to PFT, then you could consider it being asthma overlap. Very challenging, it's tough. Leslie had said that we don't have the peak expiratory flow meters, but I guess you guys have the ability to have them during the clinic visit. So something to at least know about, maybe you can get these peak expiratory flow variability patterns just when you see these patients. I think it would be of value to get these in your clinic and have them available, especially for truly asthma patients and the ones that have severe persistent asthma. But that's something that you guys might have to look into. Gotcha. And another question was when you have seasonal rhinosinusitis allergic disease. So you could put a different clarification on their severity, like mild or moderate during different seasons, mild during the winter, moderate during the spring. So people sometimes could even preemptively increase their therapy in these situations. But it's something to at least keep an eye on. And arguably, you might be able to do immunotherapy, right, for these patients. And all of a sudden, they could stay mild year-round if they do immunotherapy for the triggers that are worse during the winter. Yep, and I see Drew, he said that dry powder inhalers are terrible. Yep, exactly, so they're not aerosolized out. These are things that you have to suck in and breathe hard and fast to get these inhalers and medications into your airways. The downside for the aerosolized inhalers that are not dry powder is I guess they can potentially cause some degree of pollution in the environment. I don't know if it has to do with ozone problems or not. But that's the reason that some people are moving towards dry powder inhalers. It's more eco-friendly. And certainly, like Drew said, a rescue inhaler with dry powder is terrible. Yeah. All right. Any other questions I can help to answer from anyone? Very good. Very good. Very good. Thanks for the compliments, guys. Appreciate it. I really appreciate your guys' time, and I hope you guys have a great rest of your day.
So thanks, Patrick. Thanks for coming. I'll upload this to the Silver Fridge today or tomorrow once it gets processed. So thanks everyone for watching.